Okay. So our lecture for this morning is a lecture on the abdominal wall, the omentum, and the retroperitoneum. Okay. So the textbook. Okay, of course, still most of the information is from Schwartz and from Sabiston. Okay. So the margins of your abdominal wall cranially. Okay. Of course, you have to feel your costal margins. Okay. Costal margins, and of course, in the midline, your xiphoid. Okay. That's why usually when we draw for example, when we are in our charts, okay, you will see us draw, okay, xiphoid, and then subcostal margins, okay. Then below you have your pubic bones, okay, down to the pubic tubercle there, okay. Then of course we draw our lateral lines, okay. So for example, we're doing our physical examinations. We write in the chart, I feel a palpable mass here, okay, or there is pain on this area. Okay, that's how we draw it. Okay, so your abdominal wall provides support and protection of the peritoneal and your retroperitoneal organs. Okay, in Sabiston, it says your abdominal wall has additional functions. Okay, and one of those is it actually helps in respiration. Okay, so when your abdominal muscles relax, okay, it gives time for your diaphragm to pull down, okay, and thus expanding your thorax. Okay, when you exert effort in your abdominal muscles, what happens? It also decreases your functional residual capacity. Okay, and then the third function is in Valsalva. Okay, so when we have to expel something, okay, like for example, you are constipated, okay, or you already have some prostate problem, okay, and you have difficulty urinating. You use your abdominal muscles to help you expel so that you can urinate or you can defecate. Okay, of course, for our female colleagues who are here, okay, they also use their abdominal muscles when they deliver their babies. Okay, so those are the additional functions of your abdominal wall. Okay, so we have to review our anatomy. Okay, but if you take note, most of the time in our lectures in surgery, we always go back to anatomy. Okay, and this is not only a review, okay, but to impress to you that surgical anatomy is different from your generic anatomy. Okay, so in first year when you were dissecting your cadavers, everything was open, correct? Okay, you had an abdominal incision, for example, it's very large. You're able to see everything. Okay, in surgery, of course, you cannot do that. Okay, and we will learn that later on in the abdominal incisions. Okay, we also have to review our embryology. Okay, we know for a fact that our anterior abdominal wall is derived from mesoderm. Okay, and these actually are bilateral migrating sheaths. Okay, they are sheaths. They come here from the paravertebral area. Okay, and they start to fold. Okay, when the embryo is folding, okay, there is a folding of your lateral. Okay, we know, of course, there's a caudal, there's a cranial folding as well. Okay, so when the embryo is folding, okay, it will develop your thoraco-abdominal cavity, which will later on be divided by your diaphragm. So the lateral folding, by 7 weeks, it's already at the linea alba. By 8 weeks, okay, it's already at the, it closes your umbilicus. Okay, so a review of the layers of your abdominal wall. Okay, of course, you have your skin, your subcutaneous tissue. Okay, and under your subcutaneous tissue, you have your superficial fascia. We have two of those, your campers and your scarpas, and then the different muscles, and then your transversalis fascia. Okay, after your transversalis fascia, you already have your preperitoneal adipose tissue, and you are already in your peritoneum. Okay, so if you take note here, I've placed codes, okay, so that we can easily follow the lecture. Okay, so now we are at the level of your fascia, okay, your superficial fascia, your campers and your scarpas fascia. So these are actually very thin fascias, okay, but when you are a surgeon, okay, when you are dissecting, you will definitely encounter this as separate layers. Okay. And the way I remember this, okay, how do I know that the campers is the first layer that you encounter? Okay. So for those of you who are familiar with the fish carpa, okay, so you have to camp first. Okay, you have to build your camp first before you can cook the carpa. Okay, so I don't know if that will help you. Okay, but that has been my way to remember it. Yeah, when I was in med school. So until now that I am already a practicing surgeon. Okay, so your scarpas fascia, actually, if you follow it, okay, if you follow it, it fuses now with the fascia of the flank and the back. Okay, so it's like a surrounding fascia. It fuses with your fascia of your flank and your back. Okay, so this is an overview of the muscles of your anterior abdomen, okay, in different layers. Okay, of course, we're going to, we will not be discussing all of them. Okay, like for example, your pyramidalis, which can be absent in some cases. Okay, because this is just a review of anatomy. Okay, so okay, medially muscle. This is a paired muscle. Okay, and rectus means straight. Okay, in Filipino, if you hear someone say recta ko na, recta, okay, it means you can hear that, for example, from mechanics or even the gasoline boys. Okay, recta means straight. Do I go straight already? Okay, so rectus means straight muscle. It's paired, and the origin is in the pubic symphysis, and the insertion is in the xiphoid process. Okay, as we go laterally, it also inserts into the fifth and the sixth ribs and the seventh costal cartilage. Okay, and then you find three tendinous insertions. So if you are a bodybuilder, okay, this is where you will get your abs. Okay, so every space between your tendinous insertion, if that builds up, if that bulks up, then that will be your muscular abs. Okay, and of course we know that your rectus muscle is covered by your aponeurotic sheath. Okay, that's why we have what we call your anterior rectus sheath and your posterior rectus sheath. So, so if this is your muscle, okay, you have an aponeurotic sheath in front. That's your anterior aponeurotic sheath. You have a posterior aponeurotic sheath, okay, known as your posterior rectus sheath. Okay, so that is in the middle. Okay, and then laterally, okay, you have three muscles. Your so we are now at the level of the muscles. Okay, so you have your external oblique, your internal oblique, and your transversus abdominis muscle. Okay, so your external oblique muscle, okay, it originates from your eighth rib, okay, and it inserts into your linea alba, okay, in the midline, and your anterior iliac crest, okay, so your anterior iliac crest. So to remember again your external oblique, so this is just a review for everyone, okay, it's just like putting your hands into your pocket, okay, so if you have a jacket pocket, okay, you put your hands like that. That is the direction of your external oblique. Okay, so the muscles go towards. Okay, so the arrow is here. It goes towards medial and caudal. Okay, so it goes towards the middle and downward, medial and caudal. Okay, so that is your external oblique. Your internal oblique muscle, okay, the origin is the thoracolumbar fascia, okay, and it inserts into the xiphoid process and the lower costal margin. Okay, so from the back, from the thoracolumbar fascia, okay, from the back, it goes anterior, okay, so it goes in front and it goes up. That's your internal oblique muscle. So it goes from the back, from the thoracolumbar fascia, it goes anteriorly and going upward. Okay, that's why the insertion is in the xiphoid process. So anterior and cranial. And lastly, your transversus abdominis muscle. Okay, the origin are your costal margins and the lumbar fascia. So it shares the same origin as your internal oblique. Okay, and it inserts into your linea alba. Okay, and the direction now is anterior. So just like your internal oblique, it comes from the back and goes anteriorly. Okay, so anterior, but the direction is it's horizontal. Okay, that's why it's called transverse muscle. So transversus abdominis muscle. Okay, so those are your uh, three layers of lateral muscles. So you have a medial group, which is the rectus, and you have your lateral group. Okay, so after that, you have in some anatomy books, they discuss the pyramidalis. Okay, but if you remember from your anatomy, the pyramidalis is not always present. Okay, uh, and it's a very small muscle. And after your muscles, you now have your transversalis fascia. Okay, I already removed the slides for those. Transversalis fascia, your preperitoneal fat, and you are now in the peritoneum. Okay, so all three layers provide aponeurotic sheaths anteriorly to your rectus muscles. Okay, but This is one of the important things that you have to remember. Okay, we have what we call your arcuate line, and this is a line around 10 centimeters below your umbilicus. Okay, 10 centimeters below your umbilicus in an adult. Okay, where the anatomy now changes. Okay, where the anatomy now changes. Okay, so uh, in order to appreciate this, okay, we have here, so this is a picture from Schwartz. Okay, if you are reviewing, you can always go back to that. Okay, so here they made a cross cut above the umbilicus, okay, above, and this is how it looks like. And they made a cut below the arcuate line, okay, to appreciate the difference. Okay, so the important thing to remember here is your internal oblique muscle. Okay, your internal oblique muscle above the arcuate line. Okay, the aponeurosis of your internal oblique muscle above the arcuate line divides. Okay, it divides. So above the arcuate line, one half provides aponeurotic sheath to the anterior rectus. The other half provides aponeurotic sheath to the posterior rectus sheath. Okay, so that is why the anterior rectus sheath above the arcuate line is composed of your aponeurotic sheath from your external oblique and your internal oblique. Okay? And then your posterior rectus sheath, is composed of the other half of your internal oblique muscle aponeurosis and your transversus abdominis muscle aponeurosis. Okay? So the important key there is the internal oblique muscle. Okay. Below the arcuate line, what happens? Okay? So it's as if they went into a rally, okay? And they all went forward. Okay? They all went anteriorly. So there is no more an aponeurotic sheath below. Okay? So that below the arcuate line, you do not have a posterior rectus sheath anymore. Okay? You only have the transversalis fascia. Okay, so the transversalis fascia is here. Okay, and it is the only intervening tissue between the rectus muscle and your peritoneum. Of course, you have your preperitoneum. Okay, but the only intervening tissue now at this point is your transversalis fascia. Okay. So at the deep surface of your anterior abdominal wall, okay, we have what we call your folds. Okay, there are folds that we see. Okay, so we are going deeper and deeper now, and this is a view from inside. So if you were to remove the anterior abdominal wall, this is going to be your view from inside or from the posterior. Okay, so if this is your umbilical, okay, so inferiorly you have your paired, okay, you have your medial umbilical ligament, and your median umbilical ligament. Okay, and this are under your medial And all of this have folds in the peritoneum, okay? And they are called either your medial umbilical or your lateral umbilical folds. Okay, so we know for a fact that these are parts of your vessels during the fetal stage of patients. Okay, but when they transitioned into the neonatal circulation, these arteries and vessels started to fibrose. Okay, and they end up becoming these ligaments. Okay, so your median umbilical fold is of course your urachus. Okay, your medial umbilical folds, okay, were umbilical arteries before. Okay, we also have these umbilical folds. Sorry, not umbilical folds. We also have these peritoneal folds, okay, where your inferior epigastric vessels are. Okay, but of course these are functioning structures. Okay, at this point, above, okay, you have your falciform ligament. Okay, so this is your view from the posterior. Okay, how about the blood supply of your abdominal wall? Okay, we have deep abdominal wall blood supply, and the major blood vessels are your superior and inferior epigastric vessels. Okay, your subcostal and lumbar arteries and veins are also there, but they only give a minor support to your anterior abdominal wall. The major support is from your superior and inferior epigastric vessels. Okay, the superior epigastric vessel, okay, the superior epigastric vessel is the final branch of your internal thoracic. Okay, so internal thoracic, once it crosses the costal margin, it is now renamed into your superior epigastric vessel. Okay. Your inferior epigastric vessel, okay, remember your inferior epigastric vessel is important in the discussion of inguinal hernias. Okay. So this is the same blood vessel that we are talking about. Okay. Your inferior epigastric vessel, okay, will tell us if we are dealing with a direct hernia or an indirect hernia. Okay, so your inferior epigastric vessels comes from your external iliac arteries. So from the aorta, it branches off to your internal and external iliac arteries. The external iliac artery now gives off your inferior epigastric vessel. Okay. So that is the deep, okay, and the superficial abdominal wall. Okay, you have a lot of smaller vessels there, giving blood supply to your abdominal wall. Okay, like your superficial epigastric, your femoral vessels, your superficial external pudendal, and your superficial circumflex. Okay, so they all contribute to the vasculature of the abdominal wall. The venous drainage is, of course, variable, but still it follows your arterial. Okay, so if we say superior epigastric artery, then it has its partner superior epigastric vein. So that is just what it means. Okay, the lymphatic drainage, okay, is the reference point is the umbilicus. Okay? Above the umbilicus, your drainage goes to your superficial axillary nodes. So it goes up to your superficial axillary nodes. Below the umbilicus, okay, it goes down to your inguinal nodes. Okay? At the level of your umbilicus, of course, it can go down, it can go up, but an additional location where lymphatic drainage goes is to the hepatic nodes. Okay? So from the umbilicus, it can go up, it can go down, but an additional would be it can go to your hepatic nodes. Okay. How about the innervation of your anterior abdominal wall? Okay. So sensory-wise, you have afferent fibers from your T4 to L1. Okay. And this is segmental. So remember, your sensory is segmental, and you may be familiar with this one. Okay, the dermatomal sensory pattern. Okay, and of course, the easiest to remember would be your T10. Okay, because that is at the level of your umbilicus. Okay, so sensory, you have your dermatomal sensory pattern. Motor, you have efferent branches of the spinal nerves from T6 to T12. Okay, T6 to T12. Okay, I removed the slides on physiology. You can review this on your own. These are just the movements of your anterior abdominal muscles. Okay, so review what are the muscles that contribute to flexion, what are the muscles that contribute to rotation. Okay, so for example, you want to rotate your trunk to the right, you rotate your trunk to the left. Okay, so what are the muscles that contribute? Okay, so we now go to the answers to the quiz. Okay, so the reason why we are discussing the anterior abdominal wall, okay, is because this is the meat of general surgery. Okay, probably more than 80% of our procedures, okay, are through the abdominal wall. Okay, so it is important for surgeons to understand the abdominal wall. Okay, and when we make incisions, okay, what is our goal? Okay, our goal is, of course, to make sure that our incision will give us an adequate exposure. Okay, but at the same time, it will minimize the effect on the abdominal wall function. Okay, it will minimize the effect on the abdominal wall. Okay, so it is interesting to tell you, okay, that of course at the start of the 19th century, when surgeons were operating then, okay, the description of an adequate exposure is totally different. Okay, before, their mantra is never compromise exposure. Okay, never compromise exposure. So that means before, if they're going to operate new for a it's going to be a very large horizontal incision. Okay, can you imagine that? Let me try to draw it. Okay, so before, if for example you have an appendectomy, they can explore up even for simple appendicitis. Okay, or they can do a very large horizontal incision like that. Okay, because they said before, never compromise exposure. Okay, so they want the exposure to be as large as possible. Okay, but of course now in the modern era, that is no longer our thinking. Okay, so just to make incision that will be enough for you to do the procedure. Okay, because of course that will have a lot of possible morbidities. Okay, number one is abdominal wall function. Okay, number two, just like in when we are discussing your laparoscopic surgery, okay, the smaller the incision is, it means the lesser the pain medication that you need, the lesser the time of recovery. So before, it is not unheard of that if you underwent appendectomy, you will be in the hospital for 2 to 3 weeks. Okay, because you have a very large incision uh, that you are taking care of. Okay, and now the incisions are smaller, even if it's not laparoscopic. The incisions are smaller. So letter F here. This is your Macbonis incision. Okay, and that was the initial or the original in. So after the never compromised exposure, this is the incision that was made for a smaller incision for appendicitis. Okay. Remember in the quiz, it says what is the modern incision for appendicitis. Okay. So now, okay. So of course you still have to identify your Macbonis point. Okay. But instead of doing an oblique incision like this, okay, we now do a horizontal incision. Okay, a horizontal incision. Okay, at this point, so this is the boundaries of your rectus. Okay, so we do not approach that the rectus. So the incision would be just here. Okay, so from here, if you're going to cut the muscles, okay, probably the only muscle you're going to encounter at this point would be the last fibers of your external oblique. Okay, so it means you have lesser disruption of muscles. Okay, so this is called your Rocky Davis incision. So this is now the modern incision for appendectomies. Okay, no longer the Cocker, the Macbonis. Okay, so question: why is that better? Okay, why is that better? Okay, so a Rocky Davis incision, okay, is straight, so that if in case you need to extend your incision, okay, it would be easy to extend laterally, extend medially. For example, you opened up and it's not acute appendicitis, so you need to do an explore lap. You can extend it like that. Okay. What about if you do the Macbonis incision? Okay. So this is very difficult to extend. Okay. So the only way to extend is to, from here, you have to curve it so that it can go that way. Okay. Or you have an additional curvature here. Okay. So you see the difference. Okay. Why Rocky Davis is being used now. Okay. So what else are the consideration? The incision should be proximate to the operative target. So this is the reason why we have different incisions. Okay, so if your diagnosis is like this, you have a different incision. So this is again to emphasize, okay, that surgical anatomy is not general anatomy. Okay, so for example, we do not make a very big incision so that you can see everything, because uh, that that would be very morbid for the patient, okay, to be taking care of a very large incision. Okay, so that's why some people who don't understand this, okay, would say, Doc, you were already inside my abdomen. Why didn't you see, for example, uh, in the discussion of inguinal hernias? Okay, we've said that there is a 12% possibility of a bilateral hernia. Okay, but of course, when we operate on a hernia, we do a other side if there are no symptoms. Okay, because that would mean an additional incision. Okay, so for if the symptomatic side is just the right, then we just do a right-sided incision. If in the future this patient develops a left, then that's the time we open the left side. Okay, we don't do a large incisions just so we can see the other side. Okay, so sometimes you hear patients and sometimes even doctors, okay, non-surgeons, okay, would say, Doc, you already went inside the abdomen. Why didn't you see that? Okay, so and we have to explain this to them. Okay, that surgical anatomy is different from your general anatomy. Okay, you don't explore just because you want to explore. Okay, there should be an indication for you to explore. Okay, of course, with this many incisions, okay, incisions can still be surgeon dependent. Okay, so for example, what is the surgeon? Probably the choice of the surgeon has been honed through several years of practice already. Okay, so sometimes we still see patients status post appendectomy with a Macbonis incision. Okay, that's still possible. Okay, or sometimes uh, we had one consultant in the Philippine General Hospital when he does his gallbladder surgery. Okay, so 98% of the consultants do a Cocker's incision. Okay, one of our consultants do a transverse incision here instead of the Cocker's to access the gallbladder. So again, that's a surgeon-dependent decision. Okay, and that is what he is an expert with, an expert on. Okay, and incisions can also be patient dependent. Okay, so of course this will depend on the status of your patient. So in the quiz, I asked, what is the best incision for a patient who is malnourished and you need to do an explore lap? Okay, so the midline incision, okay, is usually used for exploratory laparotomies in the adult. Okay, but if you encounter a patient who is malnourished and you need to do an explore lap, okay, sometimes we do the paramedian. Okay, instead of a midline incision, we do a paramedian. What stage of the paramedian? Okay, in when you do a midline incision, okay, and you start to close, you're done with the surgery. So you start closing the abdomen. If you did the median incision, okay, you will only be closing one layer, and that is your linea alba. Okay, you will be only closing one layer. While if you do a paramedian, you cut through the anterior rectus sheath, you cut through the rectus muscle, you cut through the posterior rectus sheath before going into the peritoneum. Okay, when you repair, when you start closing, you actually repair in several layers. Okay, and this gives an advantage. Okay, because it will lessen the risk for dehiscence. Okay, so those are considerations in terms of patient. Okay, or what if you already have a patient who had an explore lap before and again needs an explore lap? Okay. So, for example, this patient underwent an explore lap, and this is his incision. Okay, not the hole, not a coast-to-coast incision. Okay, so probably a patient had only mostly an upper abdominal problem. Okay, so that is incision. And now the patient is complaining of another problem, and you need to do an exploratory laparotomy. Okay. What we do is we still use the same incision, okay, but we have to add fresh areas. Okay, so we can probably extend it here. Okay, extend the incision here. Okay, like that. Okay, and when we start to open, we open it here in the fresh areas. Okay, why do we do that? Do you have any idea? Can we hear from Mildred?
But I'm not sure.
Okay. Anyone? Okay. So we always start with the fresh areas. Okay. Because there is a possibility that you have adhesions. Okay. In the previous incision site, there is a possibility that there are adhesions in that area. Okay. So if you have to reopen and you have to go through the same incision, there are no adhesions, and then we open the area. Okay, so that is the reason. There's always a risk, okay, that there are adhesions in the previous incision site. Okay, so of course you're going to do a disservice to your patient. So for example, this patient already had a previous incision like this, okay? And then you decide, I'm going to do an incision like this. Okay, can you just imagine the functional problems that it's going to give your patient? Okay, and of course the aesthetics. Okay, so the patient will have a crossed scar in his abdomen. Okay, and of course that's not good. Okay, so this just means, for example, if we have an adult patient with a previous incision like this, when he was a baby, probably he had the surgery when he was a baby. When we do our explore lap, even if it's already an adult, the patient is already an adult, we can just extend this one. Okay, so that is just one incision. Okay, so as much as possible, we don't make crisscross. Like for example, you already have that incision and then you want to add to make this incision. Okay, so of course that will not be good with the function of the patient. Okay, so we're going to discuss the incisions one by one. Okay, and here you will be picking up the answers to the quiz. Okay, so the midline incision, okay, that's letter A, the midline incision here. That is what we call your exploratory laparotomy. Okay, that's your EL or your XLAP incision. Okay, and you go through the linea alba. Okay, the reason why it's very popular, okay, because when you go through the linea alba, there is no blood vessel to think about. There are no nerves that you're going to encounter. Okay, so for example, you are dealing with a trauma patient and you need to open the abdomen very quickly. Okay, then you can do a midline incision and that will be very quick. Okay, because you're not thinking, oh, there are blood vessels here, oh, there are nerves here. Okay, so that is the advantage of the midline incision. Okay, you can go quickly in. Okay, your patient is unstable, you can go quickly out and repair. Very easy. Okay, so that is letter A. And then you have letter B here, which is the paramedian incision. So para means to the lateral to your median. So lateral to your midline, it can be on the right, it can be on the left. Okay? And it goes through your rectus sheath and your rectus muscle. Okay, the advantage, as I've discussed earlier, you have several layers to repair. Okay, so of course you cannot use this for trauma patients. Okay, even if that patient is malnourished, okay, and the patient needs to have an explore lap quickly, you cannot do the paramedian. Okay, you have to go through the midline. Okay, you have to think of treating the problem first, the liver. Then okay, but you have an elective surgery, your patient is slightly malnourished, or you have diagnosed this patient to have a collagen disease, okay, then your paramedian incision is the best alternative, okay, because you have a stronger repair post-op, okay. So your paramedian incision is also used for explore lap, okay, but if you look at it, you will have less, unless you create a very long incision, you have less view at this area. Okay, so you probably will have a good view of this area. Okay, but this area not so good. Okay, because your incision is here. Okay, but it can still be negative to your explore lap. Okay, transverse incisions. Okay, so we have your transverse or your horizontal incisions. Here it's letter G. Okay, but actually the incision in the right is the more common one. So this is usually used in pediatric explore labs. Okay, so for example, I'm a pediatric surgeon. Okay, when I open up, for example, babies with duodenal atresia, with malrotation, with jejunal atresia, ileal atresia. Okay, this is the usual incision. Okay? It's just like letter G, but it's on the other side. Okay. If we're thinking that it's a lower abdomen problem, you can do it lower. Okay, this is called an infra-umbilical transverse incision. This is a supra-umbilical transverse incision. Okay, and then if you really need to explore the abdomen, you can always extend. Okay, you can make this longer, either laterally or to the opposite side. Okay, so this, according to studies, a transverse incision actually has a lower risk for your incisional herniation as compared to your longitudinal incisions. Okay, and why is this our explore lap incision in pediatric patients? Okay, because pediatric patients are actually wider than longer. Okay, if you look at the abdomen, it's actually wider than longer. Okay, so that's why this is the better incision. Okay, so we go to our oblique incisions. Okay, so if the skin incision is oblique, okay, and by the time you encounter the muscles, okay, you can have a choice to either split it, meaning you pull it aside, okay, instead of cutting through. Okay, so you can do either. Excuse me. You can do either a muscle splitting or a muscle cutting procedure. Okay. So letter C is called your cockers. Okay. But if you make an incision to the left side that is no longer cockers, we call that a subcostal incision. Okay. Of course, C is a subcostal incision to the right. And it has an eponym, Dr. Cocker. Okay. But if you do it on the left side, for example, you pray the spleen, okay, then it's no longer called a cockers. Okay, the cockers is used for gallbladder surgery or simple liver surgeries. Okay, so that's your cockers. And then next, your letter D is your chevron incision, or sorry, wrong spelling. It should be roof, ROOF, rooftop. Okay, so it looks like a rooftop. Okay, this is a bilateral subcostal incision. Okay, and that is called your chevron incision. We use this for more complicated procedures. So, for example, you're going to do liver resection, you're going to do pancreatic resection. Around 2 weeks ago, we had a patient with a bilateral congenital diaphragmatic hernia. Then, but we did not complete the surgery on the right. Okay, but the best incision would have been a bilateral subcostal incision. Okay, so that's called your your chevron. Okay, and if you've already done your chevron and you still need additional exposure, then we have what we call this extension. Okay, at the point at the top of the roof, you make a midline incision. Okay, and now you have what we call a Mercedes-Benz incision. Can you see it? Okay, for those of you with Mercedes-Benz cars, okay, so it will look like that. Okay, can you see it, Dr. Elijah? Do you see that in your Mercedes-Benz car?
Yes po. The
Okay. Buti pa si Elijah Mercedes. Nakachideng. Okay, so in the quiz, it says what is the baseline incision for the Mercedes? Okay, the answer is Chevron. Okay, and then we go to your Macbonis Incision. Okay, again, that's letter F. So this is the classical appendectomy incision. Okay, but the more modern incision now is your Rocky Davis. Okay, so you see there the blue line. Okay, that's your modern appendectomy incision for your simple appendicitis. Okay, and then letter H is your fan and steel. This is a horizontal, so it shouldn't be here under oblique. This is horizontal. Okay, it follows the bikini line of in the pubic area. Okay, so that even if you are already post-surgery, you can still wear your two-piece bikini. Okay, that's not a joke, huh? Some patients actually request that. Okay, so for example, if I have a female patient with appendicitis and they cannot afford, for example, a laparoscopic surgery because laparoscopic surgery would entail additional cost for the lap machine. Okay, they would say, Doc, pwedeng bikini line cut. Okay, can you do the bikini line cut? Okay, that's the fan and steel. Okay, so we access the appendix, okay, through this incision. Okay, so the fan and steel, the incision in the skin is horizontal. Okay, but when you arrive at the rectus, you still do a midline incision. Okay, so but when you close, the patient will only see the fan and steel or incision. So this is very common in obstetric and gynecologic procedures. Okay, but of course, general surgeons also do this. Killer experience is female patients with appendicitis. Okay, they request this, Doc, can I have the bikini cut, please? Okay, because I love to go to the beach or to the pool, to the swimming pool, so that I can still wear my two-piece bikini. Okay, so we do that. And then we have what we call your Rutherford Morrison incision. This is your Rutherford Morrison incision. Oblique. Okay, so it in contrast to your subcostal, okay, we follows it's also oblique, and you can use this as an access if it is here on the right to your ascending colon, if it is here to the left to your descending colon and to your sigmoid. Okay, when they also do kidney transplant for the receptor, okay, for the patient receiving the donated kidney, okay. So if you understand transplant, not remove old or the native kidneys, okay. When we give the extra kidney, we put it here at this area, okay. So we do this Rutherford Morrison incision. We access the epigastric vessels. That's where we anastomose the blood vessels of the new kidney. So the new kidney will be here. It will not be where the old kidneys are. Okay, so a patient status post kidney transplant will have 3 kidneys. Okay, although poorly functioning, the native kidney will be functioning, your new kidney will be here at the pubic area. Okay, what are additional incisions? This is called a combined thoraco-abdominal incision. Okay, and this will open the abdomen and the thorax. This is done for esophagectomies. Okay, just one of the incisions in esophagectomies. Okay, and if you have cases with a gastroesophageal junction tumor, okay, so you can do that. We do that incision. This is a J incision. So initially it's straight, okay, and then while it approaches the pubic tubercle, it goes midline. Okay, this is a very special incision, specially indicated for pediatric patients. Here, a pediatric patient with a colostomy. Okay, so we do not want to do a midline incision in a pediatric patient. Okay, we said that that is not the best incision for a pediatric patient, and also a midline incision would be very near the colostomy. So the risk for a surgical site infection is very high. Okay, so we don't bring it there. Okay, so we do a paramedian here. Okay, but because we're going to do a lot of dissection at the rectum and the anal area, we bring it to the midline. Okay, so it becomes a letter J incision. Okay, in the textbook, they also discuss laparoscopic access. Okay, but of course, we already have a separate lecture for this. Okay, so we don't need to discuss it under here. So what are the possible complications of all those incisions? Okay, number one, you have your hematoma or seroma formation. You see this CT scan of a patient with a rectus hematoma. Okay, so that's blood because it's brighter than the rest of the soft tissue. Okay, so acute bleed is brighter. You don't even need to give contrast. Okay, so hematoma or seroma formation. You can have surgical site infections. Okay, just like this one. So an incision here, now very erythematous. There's erythema. Okay, although you cannot see pus coming out yet, that's already considered a surgical site infection. Here we have a patient with a wound and a fascial dehiscence. Okay, so this is an adult patient. Look here, patient has a colostomy and a midline incision. So this is the reason why we do the J incision in pediatric patients, so that your surgical incision would not be near your stoma. Okay, because that becomes a risk for your surgical site infection. Okay, and then of course, incisional hernias. Okay, like this one, this patient had a previous lower midline incision, so it's not. So take note, the midline incision doesn't need to be always coast to coast. Okay, it doesn't need to be from the subxiphoid to the pubic tubercle all the time. Okay, so sometimes we just do a lower midline, sometimes an upper midline, sometimes a central midline. So it doesn't need to be very big. So this patient had a lower midline incision, and now there's a bulge in the incision site. So this is your incisional hernia. Okay, in some incisions, like for the oblique, incisions, nerve injury is always possible. Okay, so for example, in patients undergoing gallbladder surgery, open, okay, they would be complaining. Some of them would be complaining of a chronic pain in the incision site, okay, because of possible nerve injury, or the opposite, hypoesthesia. Okay, there is less sensation in the area, so that that can be secondary to nerve injury. Okay, but of course, we have to sacrifice that, okay, because we have to treat the pathology, okay, so we have to give in to some sacrifices. Okay, so of course, when we talk about abdominal wall, then we also discuss about abdominal wall abnormalities. Okay, and your abnormalities can be congenital, or they can be acquired. Okay, so the congenital, you will understand this more if you actually review your embryology. Okay, there are several videos in the internet, in YouTube. You just type in, for example, embryology of the abdominal wall, okay, and you can have a short review of the embryology. Okay, so of course, this will be discussed in detail in pediatric surgery, or if it has already been discussed already, we're just going through them. Elijah, tapos na to? Na-discuss na ni Dr. Bernabé?
Yes, po.
Okay. Okay, so just a walkthrough. Okay, your abdominal wall defects. You have your gastroschisis here and your omphalocele here. Okay, so your gastroschisis is usually secondary to a vascular accident involving the right umbilical artery. Okay, and your omphalocele is a failure of the abdominal fold. So you remember earlier when I said the abdominal wall is completed by the lateral folding. Okay, so you have from the paravertebral, okay, it closes like that. You also have caudal and cranial folding. So if it does not complete, you just have a thin membrane covering your abdomen. So that's your omphalocele. Okay, we also have what we call your prune belly syndrome, okay, where you have a weak or an absent abdominal wall muscle. Okay, and in patients with the prune belly syndrome, this is where the function of the abdominal wall in Valsalva is actually emphasized. Okay, because patients with prune belly syndrome will have a problem defecating, will have a problem urinating. Okay, because their muscles cannot exert enough effort to expel fecal material, to expel urine. Okay, so these patients, of course, the presentation is a spectrum. It can be mild to very severe. And some of them would be needing multiple surgeries to strengthen the abdominal wall. Okay, we have your infantile umbilical hernia. Okay, so it's already 12 o'clock. Just give me 5 minutes more. I'll try to wrap up the abdominal wall and we can just discuss the other topics with my next lecture. Okay, so an infantile umbilical hernia, okay, is different from your adult, okay, because the problem is weakness of your abdominal muscles. Okay, when the patient starts to crawl, starts to stand up, starts to take baby steps, okay, the abdominal muscles are strengthened. Okay, so the infantile umbilical hernia actually resolves. Okay, so when the baby is already walking and the umbilical hernia is still present, that's the only time we need to do surgery. Okay, if the baby comes in at 6 months, 8 months, then we don't advise surgery at that time. Okay, so we tell the parents, let's wait for your baby to start walking, and if it's still there after, then that's the time we do surgery. Okay, these are your very complicated abdominal wall defects. Okay, the first one here is called your bladder extrophy. Okay, what happens is in the anterior abdominal wall is absent in this patient. That's why the bladder actually opened up like that. Okay, it opened up, so it's called a bladder extrophy. Okay, this is actually the right half of the bladder. This is the left half of the bladder. In between is intestinal tissue. Okay, that's intestinal tissue. So this is a complicated abdominal wall defect, okay, called your bladder extrophy, or called your distal midline syndrome. Okay, here is a patient. I think she's around 10 years old now. Not in the Philippines. She's a Russian patient. Patient had an ectopia cordis. Okay, so when she was a baby, her heart was exposed. Okay, it's out of the pericardial cavity. Okay, and we call this is a group of symptoms called your pentalogy of Cantrell. Okay, so of course it has associated cardiac anomalies. Okay, the abdominal cavity is also exposed. Okay, but they were able to, but this patient survived that. So this is called your upper midline syndrome. So this is lower midline, upper midline. Okay. Other abnormalities discussed in the textbook is your omphallomesenteric duct remnant and your urachal remnant. Okay, so again, remember in embryology, your baby was feeding. Okay, sorry. The intestines, okay, before at the 7th to 8th week, they were out of the body cavity. Okay, they were out of the body cavity, floating in inside your mother's womb. Okay, and before the 10th week, they started to come back. Okay, sometimes you have remnants of your omphallomesenteric system. Okay, so it can be a cyst like this one. Okay, so it's just a fluid collection. There's no connection. This is just a fibrous connection. This is just a fibrous connection. We call this your omphallomesenteric duct cyst. Okay, here we have a patent connection. Okay, and we call this your enterocutaneous fistula. Okay, so you have a connection between your small bowel and your umbilicus. Okay, so parents will come to you saying, Doc, it seems my baby is defecating from the umbilical area. Okay, so that's your enterocutaneous fistula. A sinus, on the other hand, okay, is an opening in the umbilicus, not in the intestine. Okay, so there's an opening here. And what could be coming out of the umbilicus is either serous fluid or even mucoid material. Okay, sometimes it gets infected, so the parents will say it's a foul-smelling discharge. Okay, and then here we have, it can be just a fibrous cord, okay, or we have what we call your Meckel's diverticulum. Okay, so we know your Meckel's diverticulum is your most common omphallomesenteric duct remnant. Okay, remember the rule of twos: 2% of the population, 2 feet from the ileocecal valve, 2 inches in length, 2 ectopic mucosa, gastric and pancreatic. This is an example of a free Meckel's diverticulum. Okay, it's free. There is no fibrous attachment. Some Meckel's diverticulum still have this fibrous attachment. Okay, but in this picture, it's free. Okay, this is a picture of your Meckel's scan, which will identify your Meckel's diverticulum. Okay, so your when we give our technetium 99M, it will be picked up by cells of your stomach, the parietal cells, okay, and in the bladder. So this is normal because there is no other area where the radioactive material was collected. In this patient, you have an area in between your stomach and your bladder where the radioactive material collected. So this is a positive Meckel's scan. Okay, so we are able to do this here in the Gupan. I had a patient 3 weeks ago with Meckel's diverticulum, and they can do it in Villaflor. Although 3 weeks ago there was still they still had to order the technetium. Okay, but they have a nuclear medicine there, so they can do that if the technetium is already available. Okay, the nomenclature of your urachal remnants follow the nomenclature of your OMDR. Okay, so you can have cyst, you can have sinus, which is the same. Okay, so here is a normal patient. Your urachus should be fibrotic already. Okay, but if it remains patent, just like your enterocutaneous fistula, okay, this is called your patent urachus. So your parents will bring a patient, doc, my baby is urinating in his umbilicus. Okay, that's the. Or you can have a cyst. Again, this is fibrotic. Fibrotic, you just have a cystic collection there. It can be a sinus. Okay, again, it can be serous or mucoid discharge. If it gets infected, it becomes foul-smelling. Okay, or just like your Meckel's diverticulum, you also have your vesico urachal diverticulum. Okay, but the most common is your patent urachus. Okay, so here are 2 patients with a fleshy mass in the umbilical area. Okay, one of them is an umbilical granuloma and one of them is a patent urachus. Okay, and I would like you to see. Okay, I would like you to see the difference. Okay, so an umbilical granuloma is usually reddish. It's very red because it's a granuloma. It has no connection below. It's not an OMDR. It's not a patent urachus. Okay, if the umbilical mass is a little faint in color, like this one, okay, you have to ask the parents. do you notice fluid coming out of the umbilicus, or fecal material, or mucoid material, or even pus? Okay, if the mother will tell you yes, doc, okay, then that's then that can either be an omphalomesentaric duct remnant or a patent urachus. Okay, so of course the surgery is different. Okay, with a granuloma, you just need to tie that off. Okay, tie that off, or in some textbooks they freeze it. Okay, they freeze it, then it will fall off on its own, or you can cauterize it. Okay, you burn it. Okay, that's the treatment. But if it is an OMDR or a patent urachus, you have to do an umbilical exploration. Okay, what we do is we do a sub-umbilical incision here. Okay, and then follow this down. Okay, it says here if it's a urachal remnant, we have to excise it because of some reports of malignant transformation. Okay, so I think I'm going to end with this slide for this morning. We lost 30 minutes earlier because I had a referral. So let's just continue on my next schedule. Elijah,
Yes, po.
will Dr. Bernabe use his Friday schedule?
Doc, I wasn't able to text him yet, pero nag-post po siya kahapon sa Google Classroom that we would meet him November 13, Saturday evening po.
November 13. Okay, so if that's the case, let's use this Friday for my missed lecture. Okay, we're going to talk about pediatric trauma. Okay, so if you want to read ahead, read on what are the nuances, what are the difference in approach when we are dealing with a pediatric trauma patient as compared to an adult pediatric patient. Okay, so I will leave you now. You can have your lunch, and I think my next lecture is 2 to 3 weeks after pa, no? Not next week. Correct? Okay, let's just review the syllabus, but I don't think it's my turn to lecture.
December 1 po, Doc.
Okay, so not next week. So we're done up to the patent urachus. Okay, so goodbye everyone. So remind me of the top 3 in the quiz today of the 5 points bonus.
Yes po, Doc.
Okay.